Thank you everyone for joining today's APHRS education webinar, Understanding ECGs and Intracardiac Electrograms in Device Therapy, Part 2. My name is Jeremy Yu. I'm the Regional Education Manager at Abbott Medical. I hope you have participated in the ECG course Part 1 on last Thursday, and it is my pleasure to be a moderator again for today's sections. Today, it is very great to have two experienced speakers, including Dr. Daniel Chung from Singapore and Dr. Vanita Arora from India, to share their knowledge. If you have any questions wanted to ask our speakers, please write them into the chat box in your control panel. We will have time for Q&A after each presentation. And when you see the polling questions on your device along the presentation, please respond with your answer. So now I would like to invite Professor Chipat Lau, the immediate past president of APHRS, and also he is the course director of the APHRS Cardiac Rhythm Device Therapy Curriculum, to give an opening speech. Thank you, Professor Lau.
Well, again, good afternoon and maybe good morning to some of you. The purpose of the core curriculum is to understand the practice of device, including pacemakers, ICDs, and CRTs. We have a structured course holding out in either Beijing and in Tokyo, including both lectures and also virtual reality workshop. Because of the COVID-19 this year, we have limitations to carry out at least the hands-on, but we make it up by holding webinars, most important on the theoretical and also practical aspects of implantable devices. We had one in the first time on the remote monitoring, and we are very happy that we have an understanding of the ECG and also pacemakers in the webinar a couple of weeks ago. So today we are very happy to move on with further education in the ECGs of intracardiac electrograms in device, especially on the using a case study format on ICDs and also on CRT. We have two good friends and expert speakers within the region. The first speaker, Dr. Daniel Zhong, who will be telling us about ICD electrograms and case studies. Daniel is adjunct assistant professor and is a senior consultant with the Department of Cardiology and the director of SAF Cardiac Fitness Center as a National Heart Center in Singapore. He is also the director of the residency program in the SingHealth Duke NUS Cardiovascular Science Academic Clinical Program. The second speaker will be Dr. Vanita Arora, who will be lecturing to us about the ECG of CRT and troubleshooting. Now, I think all of you should know Dr. Arora, who is the director and head of Cardiac EP Lab and the arrhythmia services at Max Hospital in Delhi. Importantly, she's the first lady electrophysiologist of India. And she is also a pioneer female cardiac electrophysiologist in the country. She has been with a distinguished faculty in several national and international meetings, including the APHRS. And she will be giving us the talks on the CRT and troubleshooting. So without wasting more time, may I invite Dr. Daniel Zhong to give his first speech.
Yeah, thanks, Prof. Chu. All right, so let me, so I've starting to share my slides. Okay, so today's topic that I'll be presenting will be ICD electrograms with case studies. And okay, let me just go down. Okay, so Okay, so ICD tracings, I do understand that there are more than 150 participants, and we do know that many participants have a wide range of experience, from simple to maybe more experienced persons. So we have physicians, nurses, technicians who will be attending this webinar. So I have chosen a series of ICD tracings. Some are very basic and simple, and some will be a bit more complicated. But I hope that through all these case studies that we will all learn together, and that we would, get better so that our patients get better care. And I think that ICD case studies is really the best way to learn. There will be some opportunity for audience participation. So as much as possible, if the audience could just do the poll, vote for the correct answer, and then that would really help us to know if it will work. Okay. All right. So first case. All right. So what does this ICD tracing show? All right. So without further ado, let's have a look. So this is the first case. It's quite straightforward. There's no trick here. But I just like to get the audience to be familiar with the polling. So this is a ICD tracing, and something happened over here, as you all can see. So maybe the audience can sort of have a look and decide, is this one inappropriate shock for atrial tachycardia that was successful? 2, is this an appropriate shock for VF that was successful? 3, is this an appropriate shock for VT that is successful? Or 4, is this an appropriate shock for atrial tachycardia that is unsuccessful?
Sorry to interrupt, Dr. Chung.
Yeah.
Could you please enlarge, put on
Enlarge,
full
okay.
screen of your presentation? Yes, thank you.
Okay, do you see the full screen now?
Yes, and
oh,
yeah,
okay.
if
Let
you
me
go
go
back to the
Okay,
questions.
I'm sorry. My apologies.
Yeah,
Oops, sorry.
thank you.
I skipped answer me. Sorry. Okay. Yes. Can everybody please vote? Okay. So this is a ICD. Okay. Very good. So I think that the majority got the answer correct. So this is so let me just go through this ICD tracing because maybe not all of us see this on a regular basis. We may have a mixed group with different degrees of experience. So let me just go through this tracing. So you can see on the top here that number 1, the first line refers to the atrial sense. So this is the atrial lead that is seeing what's the electrogram within the right atrium. And then number 2, the second line refers to the ventricular sense strip. So this refers to what the device is sensing in the right ventricle, typically. And then the third line are the marker channels. So this refers to what the device is interpreting as what it's seeing in the different channels. And you can see that there's a tachycardia that is fairly regular and fast. There's more V's than A's, so more ventricular beats than atrial beats. And there is a lightning sign here indicating that there was a high voltage HV delivery shock. And after that, the rhythm went back to essentially a normal rhythm. So this is not atrial tachycardia because there are more V's than A's, and it's successful because the tachycardia ends. Looking at this, it's not VF because it's very regular with a tachycardia cycle length of about 220 to 230 milliseconds. So this is number 3, ventricular tachycardia with appropriate shock, and it's successful. Okay, very good. Okay, so next question, also quite straightforward, I hope. It's a patient who presented to the emergency room in ventricular tachycardia because the emergency doctor did a 12-lead ECG and it shows VT. And the emergency doctor noted that the patient has an ICD. And so whilst the technician was doing the ICD check, the physician asked, why is there no ICD therapy for this patient who is having a ventricular tachycardia episode? Why is the ICD not delivering therapy? Is it one, under sensing? Two, is it SVT discriminators, supraventricular tachycardia discriminators withholding therapy? Three, is it a ICD pulse generator failure? Or four, is the VT, the ventricular tachycardia detection zone, set too high? All right, maybe everybody votes. I know that this is probably going to be quite easy for some of you, but I think that it is good that some of us, I mean, not everybody may be very experienced implanters or experienced doctors who are and nurses who are following up on patients. So I think it's good to sort of just go through some of these simple ones before we go to the more complicated tracings. All right, very good. So almost everybody got this correct. So I don't really need to belabor this point. Definitely, it's not under sensing because you can see that you know, for every beat up here, there's a ventricular EGM, and it's not SVT discriminators. It's turned off over here, and it's just that the VT zone is 160, but this tachycardia is going at about 150. So I think it is important. We see sometimes this happens because we have a patient with ventricular tachycardia and we give amiodarone, and we forget that sometimes if the ventricular tachycardia is already very close to the lower threshold at which we set for the VT zone, that we can actually, the VT may become slower and it may be it may not be detected because of that. So there's no treatment that's given. Okay, very good. So let me go to the next slide. All right. Third question, which is also, I think, should be fairly straightforward. What is the rhythm? Is this a sinus rhythm with ventricular ectopics? Is this ventricular tachycardia? Is this ventricular fibrillation? Is this supraventricular tachycardia? Maybe let's vote. Maybe it won't take too long because I think most people probably get this right. Is 30 seconds up? Okay. All right. Oh, okay. There are some who wrote sinus rhythm with ventricular ectopics. Okay. All right. Okay. Let's have a look at this tracing. So if we look at this tracing, we can see that this is a fairly okay. Maybe there's one ectopic here, but this is a fairly regular tachycardia. It is the rate is at about 250 milliseconds, so it is fairly fast. And other than that, actually, if you look at this, you can see that it's actually fairly consistent, 1-to-1. So it's so I would say that this would be more in keeping with a regular tachycardia, because even though this is a little bit earlier, but the morphology, I would think that it's still within the range of what we would see for the morphology. So it is, I don't think the morphology changed a lot. So looking at this, and the rate is within the tachycardia zone. So this I didn't put sinus tachycardia with ventricular ectopics as a choice. So I put the sinus rhythm, so presumably normal sinus rhythm. So I would say that this is supraventricular tachycardia because it's a one-to-one AV relationship. And if you look at the marker channels, the tick indicates that the morphology is consistent with the in the template, the sinus morphology template. So I would say that this would be more consistent with the supraventricular tachycardia. It's definitely not VT or VF. I think most people got that right. Okay, let's go on to the to this one, which is also quite straightforward, I think. All right, so recurrent palpitations, what's the cause? So this is a patient who has a CRT device, and whilst this was happening, a patient complained of palpitations. So was the cause 1, pacemaker-mediated tachycardia, 2, supraventricular tachycardia, 3, ventricular ectopics, and 4, ventricular tachycardia. So quite straightforward, this one. So please go ahead and vote. Okay, all right, pacemaker-mediated tachycardia. Okay, very good. So this is pacemaker-mediated tachycardia. Okay, so maybe some thought it was SVT, and that would be a differential. But if you look at the ray, the tachycardia terminated. So this tachycardia, so there's A sense and B pace over here, and you can see that probably a PAC over here, or maybe a retrograde A, whichever sort of started this episode of fast pacing, and it's sort of being tracked, as we can see. So this faster atrial rate is being tracked by the device, and the device detects it as a PMT, but doesn't mean that the device says it's PMT. It's really a pacemaker-mediated tachycardia. We have to see what is the response when the device initiates the therapy for PMT, which is in this particular device is to withhold one ventricular pace beat. So therefore, in this particular case, you can see that PMT is triggered. The PMT algorithm is triggered, and when it is triggered, we can see that there's no BIV pace for this particular atrial sense beat, which is sort of partially hidden within this word trigger over here. And when this happened, the atrial rate actually went back down to normal. So given this, maneuver by the device and this response, I would say that 1, pacemaker-mediated tachycardia would be the correct answer. However, if this maneuver still resulted in the tachycardia continuing, so we will have to see more beats over here. So over on the right, you can see that the tachycardia sort of terminated. Then it would be an SVT. But in this particular case, it's a PMT, a pacemaker-mediated tachycardia. So it is the response of this rhythm to this maneuver that sort of helped us to differentiate between PMT as well as SVT. All right. Okay, let's. Okay, so how will we prevent such an episode like this? I think to prevent an episode like this, one way would be to sort of maybe program a longer post-ventricular atrial refractory period so that this particular beat would fall into the PVAP and therefore would not be tracked. But in a CRT, we do know that that has a trade-off, and the trade-off is that if if this is not sensed and not tracked, potentially it can conduct down to the V, and then we would lose bi-V pacing, and the bi-V pacing percentage would drop, sometimes quite significantly. So that's the trade-off that we have to be careful of if we were to prolong the PVAP in patients like this. All right, let's go on to case 5. Okay, so case 5 is a patient, again, with an ICD and a very classical kind of a pattern on this diagram over here. And so I think most of us will already be thinking about some differentials. Okay, let me go on to the next slide. So the next slide is this. So this is the tracing of one of the events. This is not the one with the shock, but this is the one with the event. So the patient did get a 30 joule shock, but this is the tracing for one of the events. Okay, so what is the reason for patient's ICD shock? Is it 1, an appropriate shock for VT, 2, an inappropriate shock for T wave oversensing, 3, an inappropriate shock for R wave double counting, or 4, an inappropriate shock for deep noise? Maybe we can all vote and see how it is. Okay, I wonder whether most have voted. Okay. So this is what we do see from time to time. Okay. 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 All right. Do we have the results of the poll? Okay. Very good. Okay. Sorry. All right. All right. So I think almost everybody got this correct as well. So this is T wave oversensing. When we see this tram track appearance over here, I think that there are some things that immediately comes to mind. One, of course, is T wave oversensing. 2 is actually, could this be R wave double counting? That can happen as well. And some of the other possibilities could be, for example, a ventricular bigeminy, for example, with closely coupled PVCs. So these are some of the things that we would think about, but it's actually this particular rhythm strip that sort of confirms that it is T wave oversensing, because you can see the ventricular detection over the T wave. So I think there are several programming options to program around it. Of course, we can adjust the sensitivity to avoid the T wave, but the trade-off for adjusting the sensitivity to a number that is higher so that the T wave is not sensed would be potentially under-sensing VF. So that is one option. You can also adjust the sense refractory period so that it's a bit longer. And then the T wave may not be counted, but this doesn't work well if the T wave occurs quite a bit later. Options specific to Abbott would be to adjust the threshold start and the decay delay. So this is the threshold start, nominally set at 62.5%, but I guess one could increase it to 75%, for example, start at a higher level, and that would help to maybe prevent oversensing of the T wave, or the decay delay could be a bit longer, and that will also prevent or minimize T wave oversensing. There's also this low frequency attenuation that will help to sort of attenuate low frequency signals like the T wave and minimize oversensing there. So Medtronic has a T wave discrimination algorithm that would help to sort of prevent T wave oversensing, and Biotronic has this enhanced T wave suppression algorithm. Sorry, enhanced T wave suppression algorithm. So you can actually increase the high pass filter, or you can actually increase the upper threshold from 50 to 75% of the R wave. So these are some of the maneuvers that we can do to try to overcome T-wave oversensing. And for Boston, of course, they do not have a T-wave oversensing algorithm per se, but automatic gain control can be adjusted. All right. Okay, so let's come on to the cases that are not so straightforward. Okay, so this is a patient with a subcutaneous ICD with a smart pass turned on. One of my patients, 2 zones, conditional shock 200 and shock zone 220. The sensing configuration is alternate and post-shock pacing on. So it's one of my patients with Brugada syndrome. So during sleep one night, this happened. So this question I think is quite easy too, but let's just have a look. The next question, next few questions may not be as easy. So you can see that this happened one night, and then the ICD delivered therapy, as you can see over here. So this is the same rhythm strip. So what does this tracing show? Number 1, it shows an inappropriate shock for noise. 2, it shows an inappropriate shock for electromagnetic interference. 3, there was an appropriate shock for VF, but it was unsuccessful. Or 4, there was appropriate shock for VF and it's successful. Can I get people to vote, please? All right, can you hear now? Can you hear? All right. Okay, so very good. So this is actually an appropriate shock. All right, let me just let me just go through this tracing a little bit. So although I can imagine that some people may mistake this to be electromagnetic interference or noise, given that it is really very fast towards the end over here. But if you look at this entire tracing, you can see that this is consistent with ventricular fibrillation. If I go up one tracing, you can see, or 2 tracings, you can see that this patient was having nocturnal bradycardia, PVC, and PVC on the T wave, giving rise to VF, and this is not unexpected. We can see a little bit of noise sometimes on top of the VF, especially when the patient stirs in their sleep. And so even though there may be some noise over here that we see, this would still be considered an appropriate shock for ventricular fibrillation, and it is successful because after the shock is given, the rhythm is back to sinus rhythm. All right, so this is ventricular fibrillation with appropriate successful shock. However, 1 year later, the patient was playing basketball when he had to stop after feeling a shock. This was the tracing. So you can see that he was playing basketball, so his heart rate is a little bit faster now. And this was the tracing with the shock. Okay, so let me go on to the questions. Okay, so what does this tracing show? Number 1, an inappropriate shock due to movement artifacts. 2, inappropriate shock for electromagnetic interference. 3, appropriate shock for VF but was unsuccessful. Or 4, appropriate shock for VF and it was successful. Maybe let's vote. So this patient was shocked a second time just within a year, and this was the tracing that was related to that shock. So has everybody voted? Okay, maybe we can have the poll result once everybody has, or most people have voted. All right, very good. So inappropriate shock due to movement artifacts. Okay, so this is a subcutaneous ICD. So subcutaneous ICD movement artifacts can happen, and that is why we can see that in this particular case. In fact, there is actually also some T wave oversensing a bit earlier. If we could just go to this strip over here, we can see that there's some sense beats over here, and in between the sense beats there can be some T wave oversensing as well. So I'm pointing to the bottom rhythm strip. So there was both there was some T wave oversensing, but the main reason why he was shocked was due to movement artifacts. Okay, and it was not due to a electromagnetic interference because it's sort of not fast and not regular enough to be EMI, and it's not due to VF. The interesting thing for us was that the smart pass that we had programmed on when the patient came back for his interrogation was found to be off. So we were a bit puzzled. So what could be the reason for the change in this patient's smart pass configuration? All right, is it 1, bradycardia during sleep with small voltages? 2, automatic change after the first shock? 3, it was turned off accidentally by a physician, follow-up physician. 4, the tachycardia of more 20 beats per minute resulted in the smart pass being turned off. Okay, maybe let's vote and see what does the audience think. Why was the smart pass turned off? So was it due to bradycardia with small voltages, automatic change after first shock, physician, or tachycardia above a certain rate? Do we have the results? Okay. All right. So there's a smattering results. Okay. So the answer actually was actually bradycardia during sleep with small voltages. It's actually answer number 1. So this is a function of the subcutaneous ICD smart pass system, which may not be that familiar to those of us who do not implant that many subcutaneous ICDs. So basically the smart pass is sort of a high pass filter. So it filters out anything that is 9 Hertz and above, roughly about 9 Hertz and above. So you can see that usually, anything that's 9 Hertz and above is allowed through. So things that are lower frequency, that's less than 9 Hertz, are blocked. So things like, for example, R waves, which are rapid in onset, as well as VT and VF would be allowed through, whereas slower moving, lower frequency signals such as T waves by right should be filtered out by the smart pass system. However, in this particular case, this patient had actually bradycardia during sleep, and one of the safety features of the smart pass is that it will automatically turn off if it senses nothing for 10 seconds. So if it senses asystole for 10 seconds, smart pass will automatically turn off even without the physician programming it. And on top of that, SmartPass also considers certain bradycardia situations as potentially VF undersensing. So if there are 5 consecutive signals of less than 0.25 millivolts with at least 2 intervals of 1.4 seconds or above, it will turn off automatically. And in our patient, one of the reasons why he had T-wave oversensing as well as movement artifacts resulting in an inappropriate shock was because his SmartPass automatically turned off without us realizing it, and we had to turn it back on. And after we turned SmartPass back on and we got him to run on a treadmill, there was actually no significant oversensing, and the patient did not get another inappropriate shock. So this is a feature that may not be that familiar to some of us. So 5 consecutive small amplitude signals that with a longer RR interval would automatically turn off this SmartPass. Okay. All right, let's go on to case 7. Okay, case 7 is a little bit longer, so I will just give a bit of a history. It's a 71-year-old male with multiple comorbidities with a CRTD implanted. The CRT is programmed with a single VF zone at 200 beats per minute. So only one zone with ATP during charging. And the VF detection duration is 2.5 seconds. So this is the tracing, but I'm going to just expand it for you so that at least you can see the tracing a bit more clearly. So this is the initial first tracing. So you can see that it's a CRT device because there's both LV and RV. And you can see that the patient has this episode of, I would say, non-sustained ventricular fibrillation or ventricular tachycardia. It's short, then after that it resolves. Towards the end, you can see that it's sort of resolved. And then, despite it being resolved, you can see that the device still delivered 8 beats of anti-tachycardia pacing over here. So these are the 8 beats of anti-tachycardia pacing. So the question is, why did the device deliver ATP even though at this particular point in time, the patient was not in VTVF? Okay, so why did the ICD deliver ATP therapy? Is it 1, ventricular oversensing? 2, the VF detection parameters are fulfilled sufficiently for therapy? 3, ATP is committed therapy? 4, none of the above. Okay, so maybe could I just get the audience to vote? So this is, I guess, not so easy, I guess, because you may have to measure some intervals and things, but maybe I could just bring the audience through the answer after everybody has voted. So why was the ATP still delivered? Even though it seems that the tachycardia has terminated. Okay, all right. So, okay, ATP is committed therapy. Okay, VF detection. All right. So I think, so the 2 highest ones would be VF detection parameters fulfilled sufficiently for therapy. So the correct answer is the second one, VF detection parameters fulfilled sufficiently for therapy. Okay, so let's just go through basically what is the how this is so what are the VF detection parameters that need to be met? So firstly, the VF zones detection window needs to become and remain satisfied that it's in VF throughout the duration. That's 1. 2, the duration need to expire. 3, a higher ventricular zone detection window cannot be satisfied. In this particular case, there's no high detection. Detection enhancements like maybe, for example, discriminators, in this case is off. And the last detected interval is in the VF zone? And the answer is yes, the last detected beat is in the VF zone. So actually the answer is that the VF parameters are fulfilled sufficiently for therapy is the correct answer. And the reason is because if you see, if you look at the tracing, you can see that number one, you have all these beats. So 8 out of, okay, there's a bit of lag, apologies. 8 out of 10 RR intervals satisfy the VF zone. So therefore, VF is detected based on the device. The duration is fulfilled because this 2.5 seconds is the duration. And if you were to look from the point in time just before the ATP was initiated, you can see that 6 out of 10, at least 6 out of 10 of these intervals remain, all those in red, remain in the VF zone. So therefore, because of that, the VF is still on, the device still thinks VF is ongoing. And you can see that the last beat over here, I don't know whether you see my cursor, I think it's there. The last beat over here also falls into the VF zone. So when all these parameters are met, so essentially it's still considered VF and ATP therapy is delivered. So, so the answer is the VF detection parameters are met. So ATP is delivered during charging. However, if you look at over this part, with reconfirmation, there's no VF. And so because of that, you can see that the shock over here is diverted. So therefore, you do actually, so the shock is diverted. Okay, I just saw a quick glimpse of a question. I think the question to the panelists is do all of us program ATP in a VF zone? Maybe I'll answer for myself. I do program ATP in a VF zone because sometimes the tachycardia in the VF zone is not really VF per se, but it's really very fast VT. And so in that kind of scenario, ATP may still work. I will move on because of time constraints, but maybe towards the end, if we have a bit of time, maybe I'll let the rest of the panelists share a little bit more. All right. So, okay, the next question would be on this slide. Okay, the next question is on this slide. So, in this particular case, why did the device deliver the 41? So this patient this is a continuation of the patient's previous episode. So the previous episode happened. Then after that, after a couple of seconds, this episode happened. So another episode of a non-sustained tachycardia, after which you can see that a 41 joule shock was administered. So the question is, why did the device deliver this 41 joule shock, even though at this particular point in time, so at this point in time when the shock was given, the patient was not in VT or VF. Okay, why was the shock given at this particular, even though it was not in VT VF? So the options are: 1, ventricular oversensing, so therefore the shock was delivered. 2, a reconfirmation was successful and appropriate that it was VT or VF, so therefore shock was delivered. 3, the ICD was programmed to committed shock. 4, divert reconfirm is not allowed for 2 consecutive cycles. So maybe could I just get the audience to vote to say what do you think is the cause for this patient's shock, ICD shock, even though his non-sustained ventricular arrhythmia had terminated by then. So I think this is something that, again, maybe not many of us may be familiar with, but it is sometimes a cause for shocks. I wonder whether most have done. Okay, yes, okay, excellent. So the majority got correct. Okay, so it's not committed shock because in the earlier slide we can see that in the earlier slide we can see that the shock was diverted. So this is the earlier slide over here, and you can see in this earlier slide that this shock was diverted. So therefore, this ICD was not programmed to actually to committed shock mode. So in fact, the reason why was because divert and reconfirm is not allowed for 2 consecutive cycles in this device. So the reconfirmation algorithm in Boston Scientific post-charging is that if 2 out of the 3 intervals are faster than the lowest rate threshold, shock will be delivered. If 2 out of 3 are slower than the lowest rate threshold, shock will not be delivered. So in the first case, actually the 2 out of 3 intervals are slower than the lowest rate. So therefore shock was diverted. But in the second case, it was also the same. It's just that because this was the second attempt at diverting. This was the second attempt at diverting. So you can see that the device will not allow for 2 consecutive divert reconfirm cycles. So it will still deliver the second shock as a committed shock. And only after this second shock is delivered can the reconfirmation algorithm be applied again. So this is something that maybe some of us would not be familiar with, but it's a cause of shocks in patients with very short bursts of non-sustained ventricular arrhythmia. All right. What about the other companies? Biotronic, it's also a very similar algorithm where every alternate divert will not have a confirmation. Medtronic and Abbott reconfirmation occurs. So they will reconfirm prior to each and every shock. So there is some variation in the way each device company set up their device. And so this is sometimes some useful to know. Because I do not implant any Sorin or LiverNova devices here in Singapore, so I wouldn't be familiar with the Sorin, so that's why I've not included it in. All right, last case. Okay, so
excuse me, Dr. Cho, you haven't shared your slide.
Oh, I haven't shared my slide.
Yes, you just stopped sharing.
Oh, is it? Yeah, can you see my slide now?
I can see your slides. It's case number 8. Is that right?
Yes. Yes.
Okay. Yes. Sorry.
Yes. Please go. Please carry on.
Yeah. Is it okay? All right.
Yes.
Okay. All right. So this will be the last case, and okay. So this is a patient of mine who is fairly young, only in his 20s, and he has dilated cardiomyopathy, and he has a single lead ICD. So this is a single chamber ICD, and you can see that he has tachyarrhythmia. Degenerates into this one, and he gets the therapy. This is by episode 7, so very scary looking single lead ICD. Episode 8, episode 9, and okay. So okay, after episode 9, the device just stopped shocking the patient. So the patient is just stopped. So question, why did the device stop delivering therapy for VF? Was it 1, under sensing of VF, 2, rhythm return to AF, 3, ICD therapy is exhausted? Maybe let's vote. So why do you think the device stopped delivering therapy for VF? It was in between this particular rhythm strip and the earlier strips that you saw. And there were sort of 9 shocks in total for the patient before this strip. So, okay, very good. ICD therapy is exhausted. Very good. Okay, so I think a majority, majority good. So, so actually, that's the correct answer. ICD therapies were exhausted. So this is a patient, and you can see that after a series of 9 shocks, the VF therapy was exhausted, and no further therapy was delivered. So this is this can happen not only to not only to Boston devices, but to all ICDs as well, because if the ICD is designed, the ICD is designed to deliver shocks, but if after a certain number of shocks, 9 shocks, 10 shocks, whatever, if it is ineffective, the device assumes that further shocks will not be effective. Fortunately, my patient didn't pass on because he has this thing over here, which is a left ventricular assist device. So he survived, called the ambulance, and about 24 minutes later, this was before the ambulance arrived. 24 minutes later, the device started to shock him again. And the reason why the device started to shock him again was because of undersensing now. Because when after a shock, if there's 30 seconds of undersensing, the whole thing would reset. And after it reset, then essentially the therapies can restart. So we do hear of patients who get 30 shocks, 40 shocks, a VF storm. And the reason why they get so many shocks is because after the therapies are exhausted, there is a period of time whereby there may be some undersensing, and because of that, ICD therapies are reset, and then therefore the shocks can begin again. So this is what happens to my patient. So patient underwent successful external defibrillation in the ambulance, went for DFT testing and the EP lab failed. So we upgraded the patient to a higher energy device with successful DFT. Other options, if the DFT had been unsuccessful, would be to sort of consider a dual coil lead or a zygous coil, or maybe a subcutaneous coil or array. All right. So the same thing happens to the other devices, and I think that will be all for today. So maybe let me just look at. Do I have time to answer some questions, or maybe I need to pass on to the next speaker?
Hey, thank you, Dr. Chung. Thank you very much for your presentation.
Okay,
before we open to a few questions, here I would like to invite Professor Chi-Keung Cheng. Professor Cheng is the module director for this ECG webinar series, and to give us some comments to this presentation. Hi, Prof. Cheng. Do you have anything wish to add on?
Hi, everybody. Good evening from Singapore. Thank you, Daniel, for a very wonderful case presentation. As you could see, pacing and handling patients with ICDs and pacemakers is more than just implanting, because after that implantation, there's a lifelong journey that we have with the patient in troubleshooting, in managing their medical conditions, and optimizing the device status so that they derive benefit from the therapy for which we have started or implanted. So thank you, Daniel. I think it'd be interesting to go through some of the questions. I think I promised we will end on time. In the interest of time, let's take 1 or 2 questions, then we move on, because we have another speaker who will share with us on CRT and the ECGs related to CRT. So, Jeremy, if you maybe post 1 or 2 most commonly asked questions, and we'll ask Dr. Chong, Daniel, of his comments.
Yeah, sure. Thank you. So I think there is a question which is related to the case number 4. So Dr. Chong, if possible, could you please scroll a little back, scroll back to the case number 4. And the question is, why did the APHRS after PMT detection occur so early after the ASENS?
Oh, okay. So this is sort of usual, so that this is what usually happens. So when this particular ASENS is sort of is excluded from being tracked. So what happens is that if you see other devices, it will be A-sense in brackets, which means that it is effectively not sense. And so when it's not sense, the device would then time out, and at the lower rate, there will be an atrial pace at the lower rate limit that is set. So because this particular A-sense is effectively not sense and therefore not tracked, and that is the effect of the most or many PMT algorithms is to omit one A-sense, and in this particular case, that was the scenario. Yeah.
All right, thank you. And here is a second question: can you comment on the proper placement of external defib pads when a patient with an ICD?
Yeah. So all ICDs are designed such that they can external defibrillation can be performed. The recommendation is to do not place the defib pads over the ICD or touching the ICD itself. So the recommendation is maybe stay about, I would say, 5 to 10 centimeters, about 5 centimeters or to 10 centimeters away from the ICD device. So you can put it anterior posteriorly if you want, or maybe you could put it over the usual places, over the right upper chest and the left lower chest, as long as your pads are not about 5 centimeters or more away from the ICD. It would not damage the ICD. Yeah.
Great, thank you. Any further comments from Professor Ching, or?
No, I think excellent, very excellent questions and good answers. Those are typical PMT responses. And it is safe to defibrillate or shock someone, whether they have a pacemaker or an ICD. Thank you, Daniel. So in interest of time, let's move on. We have the next speaker, Dr. Vinita Arora. She will talk to us and share cases on how we could better interpret ECGs in patients with CRTs and how we could troubleshoot these CRTs. Dr. Arora, please.
Thank you so much, Dr. Cheng. Thanks for the kind words. I was just, can you see my slides, please?
Can you please share your slides again?
Yeah, just a second. Give me a second. Trying to. Okay. Can you see my slides, please, Jeremy?
Yes, beautiful. Thank you.
Okay, great. Thank you so much. Thank you, Dr. Cheng. Thank you, Dr. Lau, for kind words. And at the onset, I would just like to thank you all for giving me this opportunity. And Jeremy, I want to just make a point that in case I'm running out of time, kindly let me know, interrupt me in between, so that, as Dr. Cheng said, we have to close it in time, so we should be on time. Okay, please, I'm giving you the liberty to do that, please, and help me out.
Yes, madam.
Yeah, okay. Daniel gave an excellent presentation on ICD algorithms. My topic for discussion today is totally different. It is on CRT, the basic ECGs of CRT and the troubleshooting we can do with them. So if you can see my slide, the right side of my slide says a perfect ECG. This is what we love, a beautiful sinus rhythm, a narrow QRS, 1:1 conduction. And this is what we are aiming at patients when they show a wide QRS. Of an LBBB, left bundle branch block. We try to narrow it down so that it looks as perfect ECG as possible. But remember, CRT is an electrical solution of an electrical problem. This is what is seen on the ECG. It is an electrical problem, and we are trying to give it an electrical solution. And the QRS morphology and duration, we do, it is determined by the stimulation sites. That means where we are going to put in the leads, specifically in the RV and in the LV, and how are we adjusting the AV and VV delays in the patient, making them an individual for that particular patient. We have to individualize the programming for every patient. And slides are not going forward. Okay, so if we look at the data that we have, the patients who have a left bundle branch block, In all the ICD trials, the randomized controlled trials and the meta-analysis of that data shows that patients with left bundle branch block actually fare badly as compared to the other bundle branch block, the right bundle or the IBCD pattern. And if we adjust this to the CRTD arm, well, the patients with left bundle branch block, the nicely selected patients do very well and they have a mortality benefit with these. This modality benefit is not passed on to the patients with IBCD and right bundle branch block. And if we look at the analysis of the data, we see that all left bundle branch block patients, the women fare much better than the men, and the wider the QRS, the more benefit is transferred to these patients. However, in non-LBBB patient, this benefit is not transferred except for the patients who have a wide QRS, which is more than 150 milliseconds. Henceforth, the super responders are actually females with non-ischemic cardiomyopathy, wider QRS, and left bundle branch block. But the narrower the QRS, the IVCD pattern, or the non-left bundle branch block pattern that we say, the benefit is not transferred to them. Hence, we have the guidelines looking into all the data that we have. And this is a class 1 indication that QRS more than 150 milliseconds, left bundle branch block, LV ejection fraction less than 35%, who is symptomatic despite guideline mediated medical therapy, they become the class 1 receivers of CRT therapy. However, CRT therapy is a class 2 indications in non-LBBB patient with the rest of the parameters remaining the same. In between 130 to 150 milliseconds, it becomes a class 1 indication in case the LBBB left bundle branch block QRS pattern is there, but the level of evidence is B. It is not A, it is B. So similarly, in case the QRS width is between 130 and 150, in a non-LBBB patient, it's a class 2B indication. The class 3 indication, or a contraindication, which I should say, is a QRS duration less than 130 milliseconds. This is very clear and there is no doubt about it. Now, if we look at the ECG here, this is a 60-year-old female with non-ischemic cardiomyopathy, ejection fraction 30%, and symptomatic with NYHA class 3 despite medical therapy. Look at the ECG. Do you think you would recommend a CRT? Patrick, can I have the poll here, please? So is a 10-second over? Then we can have the result. Okay, so most of us believe that it is not the CRT is not recommended in this patient. What about if this patient has this ECG? Kindly give the poll again. What about if this ECG is there? Please, may I see the result, please? Yeah, so everybody thinks this is recommended, and that is a beautiful answer, because you see here the criterias are fulfilled. The QRS is wide, it is 150 millisecond, it is left bundle branch block, and it is, though there are some notching there, which we will just discuss, it is the indication for a CRT and a good result for that. Now, we have had a lot of trials and the guidelines which have studied the various criterias to recognize left bundle branch block from the ECG and give them in correlation with the CRT outcome in these patients. The most important thing which I want to discuss here is the mid QRS notch that we have been discussing. And if you see the Strauss criteria for the mid QRS notch, the slurring in more than 2 leads from V1 to V2 or lead 1, V5, V6, the mid QRS notch has a very high sensitivity rate up to 94% to be correlated to left bundle branch block who will benefit from CRT. Now, if we look at this ECG, please see that the QRS is wide. It is more than 120. If I can measure it rightly, it is around 150 milliseconds. It's a PR interval is okay. It's normal. And you see the notches. Just look at the notches. I've put the markers here for the convenience of everybody. The QRS width is 150 milliseconds. You see there is absence of Q waves in lead 1, V5, V6. There is a mid QRS notching which is seen in lead 3, in lead V6. So even in lead 1 and AVL. So this is the kind of pattern you look at in the ECG to advise CRT in these patients, and they will definitely benefit. Let us look at what happens post-implant also. So these are just summarizing the factors which we have to look at the ECG before recommending a CRT device to the patient. We have to look at the QRS width, QRS morphology, some notching according to the Strauss criteria, and certain miscellaneous features like fragmented QRS, like RS in V1 being more than 45 milliseconds, delayed intrinsic deflection in lateral leads, and a PR interval which may be prolonged. Now, what is the role of ECG post-CRT? Once we do the CRT, we use ECG to monitor the follow-up of the patient. We ensure good LV capture. We look at leads 1, 3, and V1. And we should be aware to look at the LV latency and anodal capture. We'll discuss about this in the subsequent slides. The detection of arrhythmia has to be seen, whether the patient is in atrial fibrillation or patient is in having frequent VPCs. You have to look at the narrowing of the QRS and optimizing the delays. The V1 has to be positive, which ensures the LV force is more than the RV force. Lead 1 is negative. That ensures that the lateral part of the LV is activated first. So there is no shortcoming to selecting a good vein and placing your lead in the posterolateral or the lateral branch of the coronary sinus. If you do a good job at the time of implant, the ECG will result into a good outcome. There will be a good, the electrical problem will be dealt with a good outcome on the ECG. So you have to look at it. Sometimes we cannot, do not cannulate the posterolateral vein, and we go in for this middle cardiac vein and go, in fact, away more apical or towards the septum. I will just show you the examples where it doesn't help. So please look at a good target vein to give a good result of CRT. When we are looking at the ECG with biventricular pacing, we have to be sure where our RV lead is, because many of us are putting our RV lead in the right ventricular outflow tract. Earlier, we used to put it at the apex, whereby we used to have the 2-3 AVF negative, and we used to have V5, V6 negative, because it used to be from the RV apex. But many of times the lead is placed in the RVOT, whereby we have 2-3 AVF, which is positive, like VPC coming from the RVOT, the similar complex it will have. And we can have, because of the placement of the lead, in case it is very distal in the RVOT, we can have lead V1 positive in these cases. So dominance of R wave in lead 1 is very important in the post biventricular pacemaker ECG. And in case the RV lead is at the apex. So this has been labeled as a positive response by Swinney et al. And the relationship between the presence and the amplitude of the paced R wave in V1 has been related to the best mechanical and hemodynamic response. In case there is no dominance of R wave in V1, we have to look at various parameters, whether there is an incorrect placement of V1, whether there is lack of capture of the LV lead, whether there is a displacement of the LV lead, whether there is marked LV latency, there is a ventricular fusion, or the pacing is from the middle cardiac or the anterior vein. We'll just discuss it in detail. And these two leads are actually the most important leads which we have to look at. In case we find lead V1 is all positive, then it is the LV pacing. In case it is biphasic, then it is the bi-V pacing. If the lead V1 is biphasic, then it is true bi-V pacing. But lead 1 altogether has to be negative, because the free wall of the LV has to get activated the earliest. So when we are looking at the LV right versus left ventricular capture, for the left ventricular capture has to be a positive V1 and negative lead 1. But if you have lead 3, which is more negative than lead 2, then right is activated more than left. Please keep a note on that. But if you have it in a good posterolateral vein, this is how your ECG would look like. Your V1 will be positive or a biphasic. The lead 1 will be negative. And you look at this, 2-3 AVF is negative, but look at lead 2 being more negative than lead 3, which means that it is the left-sided which is activated early. In case there are certain sites in the LV which we sometimes choose to pace in case we have a middle cardiac vein, well, you are in the middle cardiac vein, your V1 will be positive, your lead 2-3 AVF will be negative, but look at lead 1. You look at lead 1, this is positive. Whatever you do to do the programming in these leads, in case your lead 1 is positive, then it is you have to reposition your lead, and there is no second thought about it. This is not a good decision to leave the patient here. In case the lead is in the anterior vein, then you have placed it towards the septum. You have gone in the anterior vein. Instead of going on the lateral side, you have gone towards the septum. And when you are towards the septum, what will you will have in the ECG is actually 2-3 AVF being positive, lead 1 is positive. Even if you have V1 which is biphasic, there is an initial positive response. There cannot be a bad position for this patient, and it is recommended that instead of aiming for electronic repositioning, you should replace the lead to a better path. Sometimes what happens is that we are doing the LV threshold. You see this ECG showing you the LV threshold we are doing. You can see a different variation of the QRS. Well, the lead position is the same, but as you are doing pacing at the different output, the vector becomes different. How do you explain that? How do you explain this? The only way to explain this is probably a nodal stimulation. A nodal stimulation occurs because of the hyperpolarization of the cell, which causes the wavefront instead of depolarization, and it is a large anodal area which causes this to happen. Most of the time, the LV lead has been programmed in the pseudo bipolar mode that we call it. So here the threshold of the LV will be okay, but V1, the lead 1 will be positive. So what we can do here is to switch the LV lead into a bipolar rather than pacing between the LV lead as the cathode and RV as the anode. And this was true in the older devices. With the third generation of devices that we have as of today, this problem has been taken care of. But in the older devices, we may still see this problem. Hence, I have brought this here to take care of it. Now, when we see the ECG, we can also localize where we are pacing in the LV. In case we are more basal, which is the preferred position, then the forces from V1 to V6 will be positive. But in case we are apical, the forces will become negative in V5 to V6, thereby telling us that the LV lead is actually more apical than basal. We have to look at the QRS width response post CRT, and it has been correlated with clinical improvement. The QRS width goes down, that has been correlated with hemodynamics becoming better. But here, a word of caution that in case you have a very wide QRS, even when you connect the device and make the QRS to be narrowed, the QRS becomes narrow, but the dysynchrony is not gone. It is because of the electromechanical delay, which occurs especially in the ischemic myocardium patients, whereby the narrowing QRS does not clear off the dysynchrony in all the segments. So what is the outcome here? How can we help these patients here? The most important factor to do here is to look at the fusion vector, which I'm just going to explain you what is the fusion vector. See these leads, we are pacing from the RV lead alone. We are looking at the complex in lead 1 and in V1. We are pacing from the LV lead, which is close to the scar. And here, what we are doing is that we are having, this is the lead 1, and this is V1. When we pace biventricular simultaneously, we have to look at the lead one, whether it is looking like either of the two, either RV or LV, or it is a fusion between the two. If it is looking like one of them, then the LV lead is actually having struggle with the scar. There is a scarred area there, which is causing the dysynchronous activation of the myocardium. And what we need is the synchronous recruitment of the myocardium. So what can we do here? What we do here is that we pace the LV early. In case we pace the LV early, then we get the complex which is in between the RV and LV pacing alone. And this is a good result. We are able to actually obscure the scar which is close to the LV lead and give patient a better result because of this vector fusion. Example of a ECG which we sometimes see, somebody tells us that this is biV pacing going on, and we look at the ECG and we see that V1 is totally negative, lead 1 is positive. What do we do here? Well, this is not good biV pacing. We have to start thinking in terms of whether the LV lead is not working, or is there a too much of delay at the LV site, or there is some anodal stimulation. And if you look at this rhythm strips, there is variation. The vector is changing here. How can that be possible? Look at the PR interval. The PR interval is very short. So probably increasing the delay here if we lengthen the AV, that will help us. So in such patients, in fact, adding a medical therapy or stabilizing the dosage of beta blockers might help us to help such patients. If we see the ECG like this, there are another example of biventricular pacing. Look at V1. The V1 is all positive. If it is all positive, it is pacing the LV. 2,3 AVF is negative, which is good, but look at lead 1. Lead 1 is again positive. This has to be middle cardiac vein, and middle cardiac vein you have to, until and unless it's a really lateral site in the middle cardiac vein where you can place it, you cannot correct this thing. And a word of suggestion here is that when you are doing a biventricular pacing on the table, the most important lead that you can hook up to give you a better result is actually lead 1. You hook up lead 1 and you see whether the lead 1 is converting into a negative or a positive when you pace the LV, and that gives you the answer there and then. You may have a post biventricular pacemaker ECG, which is like this. You have given a good result. The lead V1 is bipolar. There is an initial positive complex and then negative. Lead 1 is negative. But look at the ventricular ectopic activity. These are monomorphic ventriculars, BPCs, which are coming in between quite frequently. This will not let the biventricular pacing to be at the extent of more than 95%, which we are aiming at. So it is better to take care of these ectopics, do a RFA, and just get rid of these ectopics or stabilize the medical therapy, which is very important to give a good result in these patients. A word about the frontal axis. This is, I brought it here because it is important for us to understand that with the changing technology and the recent advances in the algorithms occurring, there is some changing in the thinking which is coming here. Initially, we thought we were pacing in the RV apex, where we used to get the axis which was left superior axis. Now with the CRT and right ventricular apical pacing, the axis changes to right superior quadrant, because this is where it is supposed to be. Now more and more pacing is being done in the right ventricular outflow tract. Hence, once we have either a CRT with RVOT or LV pacing alone with the RVOT pacing, the shift is occurring towards the right inferior quadrant. So it is important to know that this shift of axis is actually because we have changed the placement of the leads and the algorithms that we are working up, which are working towards the fusion of the QRS rather than only the standard CRT that we used to have in the first and the second generation. The positive in lead B1 Whether it is completely positive or biphasic complex, it is related and it is positively related to the responder rate. However, the negative in V1 results into non-responders. We have enough data to substantially support that. So to summarize all this in a table, this table I'll just briefly discuss that if you have a dominant R in V1, it is a LV activation, which is good. But in case you have a RS or the QS pattern in V1, you have to look at various modalities to see why it is happening that there is no R in V1. And you may do the programming again, programming in form of VB programming. You may pace the LV first to try to have the dominance of the R wave in V1, or try to look at what is the reason for not having a prominent R in V1. A word about the latency and the slow conduction of the wavefront that we so commonly talk about. Now, in case we have a biventricular activation, both LV and RV forces are equally equal. We are pacing both of them at the same time, but LV is the force that we require, the myocardium that we require to pace first. So the biventricular activation time is good. But in case of latency occurs very commonly with LV pacing. It is from the pace stimulus to the initiation of the paced QRS, the time period that is taken is the latency, which occurs more with LV pacing than RV pacing, which is because of the LV pacing being done from the coronary sinus vein. It is the indirect stimulation which occurs, and there is a long distance of the electrode to the subendocardial hiss. The sequence of activation is from the epicardium to endocardium, so there is prolonged refractiveness, hence resulting into latency. So if there is a presence of latency or there is a slow conduction because of the scar, for both these things, you know, when we pace, the biventricular activation actually occurs from the RV. The depolarization starts from the RV, and that is the stronger vector than the LV. And this needs to be taken care of. Now, how can we take care of it? We have to take care of it by doing the playing with the VV delay. In case we pace the LV first, it is able to take care of the latency part, and the biventricular activation time improves. And in case we do only LV pacing, fusing it to the RV sensing, then this fusion complex or the fusion with the spontaneous QRS takes care of the latency. This is what is important, and this is what is the basis of the latest algorithms that we see in the generation 3 devices of CRT. This is the conventional biventricular pacing, whereby we program a shorter AV delay, and the native activation is replaced by a extreme axis with a pacing both from the LV and the RV, and the QRS looking in the ECG with positive V1 and negative lead 1 and extreme axis that we have just discussed. But now if we are looking at the fusion CRT, well, fusion CRT, there is a simultaneous pacing from the LV and RV along with the intrinsic conduction. The intrinsic conduction is there, and there is a fusion complex resulting in the ECG, which I'm just showing you. The QRS is narrower. There is a biphasic complex in the V1, which means it's true bi-V pacing and not only LV pacing, and lead 1 is negative, but the axis changes. The axis becomes, instead of extreme axis, it becomes the right axis. And then we are talking more and more about the LV pacing alone in conjunction with the RV sensing. This is what happens when we are sensing from the right bundle and we are pacing the LV. The QRS becomes narrow and it is as close to normal as possible, which we are aiming at. So I will just discuss a couple of examples with you whereby we have done the programming and made the patient's parameters better. This is the ECG you are seeing, the baseline ECG of the patient. If you see, the QRS width is around 140 milliseconds. There is some notching on lead 1 and even on lead V5, V6. The PR interval is short and it is normal. So this patient was given a biventricular pacemaker. Hereby, the patient is pacing from P3, which is the longest QLV which we got, and the AV delay was the nominal of 120. and we paced at the default of LV 40 milliseconds before RV. And if you look at V1, it's a beautiful positive V1. All the forces are towards the left. The lead 1 is negative. But what do we have here? What we have is a wide QRS. The QRS width is still 180 milliseconds. What can we do to narrow down the QRS to have a better result? Because the forces here are totally from the left. They are left-paced activation. What we do is that we make it less early. We reduce the LV first to 10 milliseconds before RV, and we have a better QRS. It is narrower. Lead 1 is still positive. Lead V1 is still positive. Lead 1 is negative, and this is better. So this is a standardized traditional CRT pacing that we get. Can we do more about it? Well, what we have done is we have added sync AV delta. Since the PR was short, we have added a minus 40 milliseconds of sync AV delta to the programming. And look how narrow the QRS has become. There is still a positive hump in the V1, which means a bi-V pacing. The lead 1 is biphasic, but it is a beautiful result, which has been obtained first by adjusting the VV delay, making it less early, and then by adjusting the AV delay by sync AV delta. Sync AV delta has been bi-V with sync AV optimization has been studied in various in trials, and it has been analyzed that to have given the best possible result as compared to the other algorithms which have been studied in the biventricular pacing. And then fusion optimized intervals are actually have also been studied in cardiac resynchronization therapy. It has been seen to be giving the narrowest QRS possible by the fusion optimized intervals, which has resulted into reverse remodeling of the QRS, thus giving a better outcome and better ejection fraction in these groups where fusion optimized algorithm is used. Giving another example of how important these algorithms are. This is the baseline ECG of a patient showing a left bundle branch block. QRS is around 150 milliseconds. There is some notching attached. PR is around 200 milliseconds. It's a left bundle branch block pattern. And the patient was given a CRT device. We achieved V1 to be positive. We achieved a lead 1 to be negative, which is very beautiful. And a standard AV delay was programmed to 90 and 110 milliseconds as per the device default. The QRS is good, the results look good, but if you look at lead 2, there is a notch present right in the beginning of the QRS. There is a notch which actually is not a good indication. So we played with the sync AV delta. We made sync AV delta 10 milliseconds and we lost the positive R in V1. But look at the notch in lead 2, it has become delayed. So we went further to make it to 20 milliseconds. The lead V1 still remains the same, but look at the notch in lead 2. It is getting more delayed. That means this notch, which is indicative of a scar, is actually getting delayed. So went ahead with sync AV delta at 30 milliseconds. And if you see, there is a slight hump appearing here in V1, whereby a very slight hump is coming. But look at the notch in lead 2. It is becoming more delayed. It is getting at the end of the QRS. And at 40 milliseconds, as I've highlighted, look at the notch. The notch has actually gone to the terminal end of the QRS. And in lead V1, there is a positive. It is a biphasic V1 which has come in, which is actually very beautiful. And the PR has become normal. It's 200 milliseconds. It has become normal. And the ECG looks so beautiful. It is a narrow QRS. You cannot have a more narrower QRS than this, I think. And the notch in lead 2 is just out of the QRS. It's a biphasic V1 with a very good results on hemodynamics. So sync AV actually works very nicely. You have to individualize with the patients. It works very nicely to help the patient. In case, what is standardly practiced by us is that we play with the sync AV first. We try to give the best result doing the sync AV. And in case we are not able to, or we are, there is some lacuna still remaining, then we adjust the VV delay to either making it simultaneous or LV first. And then we get the results, we try to get the results of a narrower QRS and a good ECG representation in lead 1 and V1. Here I want to add a point that, we have to keep these patients on a regular device optimization follow-up, because, once they start exercising, whatever work we have done to place the AV delay and VV delays there, it gets changed with exercise. So dynamic AV delays are very important. And in addition to that, once the patient starts to have reverse remodeling, whatever you have programmed 6 months ago does not count. So you have to keep these patients on a regular follow-up so that you can change the parameters as and when it comes and give these patients a better outcome. So looking at all these parameters which we just discussed, we have to follow this table to give benefit to the patient. Is AV conduction intact? We have to ask ourselves, we have to see the ECG, and we have to adjust the VV or the VV delay or sync AV. Is dynamic AV programmable available? If not, then we have to do it as a short AV interval to give 100% by V pacing, and we have to optimize the VV delay. And then we have to follow up these patients on a regular basis for the device setup. But whatever we do here, the most important thing to have a good responder is that we put the lead in a good position to start with, so that we are able to salvage the situation. Otherwise, nothing we do later on after putting the lead in a sub-optimal position is going to save the day. And we have to avoid any extreme programmings, and because extreme programmings, they never correct. We have to stick by the guidelines and follow them one step at a time to give a good outcome to the patient. So to summarize, 12-lead ECG provides important information for the clinical follow-up in CRT, but needs to be carefully evaluated. AV and VV delays need to be optimized on regular basis using the device algorithms and office follow-ups. Echo optimization, I don't do it anymore because we have such good algorithms available in the devices, but it can be reserved for patients who are the non-responders. RV only or LV only pacing should be performed for better understanding of the ECG during follow-up. We have to do serial ECGs and try to do the optimization and the troubleshooting by doing this. And LV pacing alone can be as effective as BiV pacing, but it has to be done in patients who have normal AV conduction. And we have to time it well with the intrinsic activation of the patient. So to get a good result, we have to know not only to do a good CRT, but to program the CRT in a correct way so that we get a good outcome on the ECG. I have a couple of ECGs here to show. Jeremy, was that you?
Hi, this is Jeremy.
Yeah, was that an indication? I heard some noise. Kind of a
Not
button.
for me.
Okay, so can we show these 3 ECGs as the quiz time for everybody? Do we have time for that?
Yes, please.
Okay, great. So this is the first ECG. Can I have the questions up here, please? Okay, so would you recommend CRT for this patient? I have just given 10 seconds time because either you know it or you don't know it. So 10 seconds should be good. Okay, perfect. So everybody agrees that this patient needs a CRT. I'm so happy. Okay. So as we discussed, the QRS width is around 150 milliseconds, and there is a mid QRS notching in lead V1, AVL, and V5, V6. So this patient is going to be a good candidate for CRT. Now this ECG, can we have the question on, does this patient need a CRT? Okay, can we have the answer here, please? Yes, exactly. So that's very good because this patient does not have a typical left bundle branch block. Patient has an IVCD, though the QRS is wide, up to about 140 milliseconds, but still he fits into a class 2B indication of a CRT. So that should not be the first line of interest for this patient. Okay, can I have the question here, please? Patrick, please. I think the question is wrong. The question is that, what do you think is the pacing here? Is it a good pacing? I think the question is wrong. So you can just answer whether, do you think it is a true CRT pacing, true BiB pacing? Let that be the question which you have to answer. Okay, if you have the answers, otherwise I'll show the answer, of course. So it is a true BiB pacing. If you look at lead V1, it is positive, or I can say it is biphasic, and lead 1 is negative. And we have a narrowing of the QRS to about 100 milliseconds. So it is a very beautiful BiB pacing that is there. You can play around with the notch as we just discussed. With the sync AV, you can play around with the notch to have this notch eliminated from lead to the center of the QRS or the QRS distally. That's all. Thank you so much for your patience and for having me here. I hope I finished in time, and if there are any questions, I will be very happy to take them.
Thank you very much for your presentation, Dr. Aroa. So let's take a few minutes to answer. There's quite a number of questions in the chat box, and let's do. This is the first questions. What about intermittent LBBB with prolonged duration? Is it a CRT indicated?
That's a very good question. This field is still not very clear whether intermittent left bundle branch block will benefit from CRT. There is no substantial data available, but as I have discussed with a couple of people, what they think is that this patient will ultimately have a delay which is there. There is intramyocardial delay which is occurring. So people have started giving these patients the advantage of CRT, even in case they are symptomatic despite medical therapy, in case the ejection fraction is low. Yes, then these patients are being given CRT. That's what I know of. Is Dr. Ching there with us? Maybe he can help me out.
Hi, Ching.
Hi, Dr. Ching.
Hi. Thank you for the wonderful presentation.
Thank you so much, Dr. Ching. I want your help to answer this question. I really don't have the data about it, but about intermittent left bundle branch block with prolonged duration. Is CRT indicated? Are you doing for intermittent CRT?
Okay, so number one, at what rate does a patient develop a rate-dependent left bundle branch block? If it's a low rate, for example, he goes into left bundle branch block at sinus rate of 70 or 80, and he has an ICD indication, then I will veer towards a CRT. If he goes into a rate-related left bundle branch at high rates, 120, 130, then I am not inclined to put a CRT. Let me tell you why. Nothing beats intrinsic narrow QRS. You can't synchronize a heart any better if the patient has intrinsic narrow QRS. And if we put a CRT in this patient, and we are compelled to biventrically pace, we are creating an artificially wide QRS. You can't beat the intrinsic QRS. So that's my position. So a difficult question to answer, but these are pointers towards CRT versus an ICD for such patients.
That's what I also thought. We don't have data on this topic, but this is a very interesting topic. There is a lot of data, in the patients who develop left bundle branch block and have a chest pain. They develop intermittent left bundle branch block and have a chest pain, which is mimics that of angina. People are doing left bundle branch block pacing in those patients. I don't know. There is no randomized data on this, but that sounds very interesting. That really sounds very interesting to look into that area.
Right. Thank you. Thank you, Prof. Cheng, and thank you, Dr. Aroa. Here's another question. It's a male, 54 years old, with non-ischemic dilated cardiomyopathy, recurrent VT, EF 30%, ECG January 2020, show LPBP QRST duration 150, but declined CRT implantation. So he had progressions of heart failure and VT, but the ECG changed to RBBP and AV block 1. Will the patient respond well if we implanted a CRT-P? Would you have any comments?
This is a very interesting situation. So the patient is a 54-year-old male, a non-ischemic cardiomyopathy, ejection fraction is 30%, is having a recurrent VT, and has from left bundle branch block now developed right bundle branch block. So he has alternative bundle branch blocks which are involved. And now he's again symptomatic with progressive heart failure. Well, if he has a documentation of a left bundle branch block earlier, and now has developed right bundle branch block with first degree AV block, as I can understand. I think implanting this patient CRT-P is a good idea because his both bundles are diseased. He's having alternative bundle branch block, and then giving him a fusion complex to narrow his QRS will be a good option, and this patient should benefit from the CRT implantation. This right bundle branch block may have come because he must have been given some medical therapy because of recurrent VT that he's having. Amiodarone is the most culprit drug which is given in such patients. So maybe he has developed, because of that, he has developed the right bundle branch block now. I don't know the details, but that's what I can think of.
Yeah, so I think very interesting case. It's a person with low EF and VT. So with that in mind, I think we probably can't avoid an ICD, a low EF and ICD, low EF and VT. The next question is to decide whether just a single chamber ICD or a dual chamber or a CRTD. And rightfully pointed out, that with medication, the axis may change. So he may not really have a true left bundle branch block. He may have conduction delay in the left bundle branch. And with progression of disease or due to side effects of amiodarone, the conduction in the right bundle slows further and it becomes a right bundle branch block pattern on the ECG. So these are very interesting concepts. It's not a all or nothing phenomenon where left bundle is blocked or conducts. It may be just slowly conducting, and the preferential conduction was via the right bundle previously, but now the right bundle is showing up abnormal conduction delay. So a very interesting case. Yeah, I think he needs an ICD, and with a previous left bundle branch block, now a prolonged PR and goes in the right bundle branch. I think it's fairly reasonable to proceed with a CRTD. Once you instrument this patient, you want to do it once and not upgrade the device subsequently because of its inevitable risk associated with an upgrade. Very interesting, this case.
There is another very interesting question I can see on the chat. That's what's your opinion regarding usefulness of RA and LV pacing instead of CRT for financially constrained patients? That's very interesting, Tushar. You are trying to make it a poor man's biventricular pace or a CRT device, cardiac resynchronization therapy. Well, if the finances are constrained, why not give a his bundle pacing or a left bundle pacing with a dual chamber pacemaker? That works actually much better than the RA-LV pacing. I would never recommend RA-LV pacing because I still feel that the sensing from the RV lead that we require, even when we are doing a fusion beat or we are pacing from the LV, that is a must, that is a requirement. You may have a RA-LV pacing, but you may result into a wider QRS because the depolarization of the LV is occurring from the epicardium to endocardium, and RV sensing is absolutely essential. So probably if the patient is financially constrained, I would put in either a his bundle pacing or a left bundle pacing rather than to do a RA-LV pacing. Dr. Ching, if you have different idea, please, if you differ in the thoughts.
No, I agree with you entirely. I am fearful of a RV-LV dual chamber pacemaker as a poor man's CRT. I do agree with you. In addition to what you say, remember, ventricular depolarization is from endocardium to epicardium. That's normal ventricular depolarization. When we put an LV epicardial lead, is LV depolarization from epicardium to endocardium. In some individuals, such dispersion may be pro-arrhythmic, and hence it is wise to have a CRT-D, you know, if they fulfill criteria. So this just me, my position and my understanding of what's in the literature in providing such therapies for this patient. I would avoid a dual chamber pacemaker, RA to LV option.
Correct. There is a very interesting question which Jeremy has posted. He said, do we only use lead 2 to look at the notch that you mentioned? The notch which I mentioned here in the case was seen on lead 2, and when lead 2 represents the left side. You know, it is the left side activation which is represented by lead 2. And it is the scar in the left side or the left ventricle which was being, which was there, which was a source of a slow area. That's why we concentrated on that to move it out of the QRS or at the distal end of the QRS, where it will not contribute to the contraction of the LV. So that is why we concentrated on that. It depends upon in which lead the notch is being seen. Here, the lead 2 was representing actually the scar in the left ventricle. That's why we concentrated on that. So,
okay, thank you. We still have a few minutes. Some of our participants, they asked about your comments about the HIS pacing. Do you have any comments about HIS and CRT?
Dr. Ching, you answer that question. I don't want to get into that controversy because I have discussed this thing a lot in many forums, but somehow, you know, we lack randomized control trials, and so we are still keeping our comments reserved. But please, you please go ahead because you are doing a lot of this.
No, okay. This is a very topical question. Would HIS bundle pacing and deep septal pacing, which is to pace the left bundle branch or the septal region, be a suitable alternative to CRT? My personal feeling, I think it's very promising. I think it seems physiological, and I hope the results are good. And I do want to await randomized control trials to see the effects of HIS bundle pacing and or deep septal pacing versus CRT or traditional RV pacing. I really want to see randomized control trials and data to make a good conclusion. But I think it's promising. But I don't wish to jump. I don't wish to jump on the bandwagon and do all of it, thinking that you know, assuming that it is promising. I remembered some time ago, just about when I was a fellow, there was a lot of interest in RVOT pacing too. Correct. You know, it seems also fairly physiological, but the results were less than anticipated. So I'll wait for that. I will cautiously await results of RCT.
Right. I mean, very well
Over
said.
to you.
Yes. In fact, there are no RCTs available. None has been started even till date. There's data available for various centers, which are a good number of cases, but not randomized. And the results are very promising, as you said. I do agree with them. My feeling is that if I have to do it, I would do all my pacemakers with HIS bundle pacing. But when it comes to CRT, I would like to wait for more data to come out, you know, before I can really say yes. I'm going for all patients in this.
All right.
All right. Thank you. Thank you very much for answering the questions from our audience. Due to the time, so we have to stop here now. And before we close, may I invite Professor Ching to give closing remarks for today's webinar?
Thank you, Jeremy. I hope everyone has learned a little bit about ICDs and CRTs. And as I mentioned earlier on, it's not just the implantation techniques that we must be familiar with, but also the post-implantation techniques to optimize the CRT, to troubleshoot an ICD, to recognize how it behaves and how the device thinks on an ECG. So I want to thank the previous speakers, Dr. Daniel Chong, Dr. Aurora, for their wonderful talks. And I hope it will give you, or rather it would cause the attendees to have a greater interest in ECGs and EGMs and the peculiar therapies provided by ICDs and CRTs. And I want to thank Abbott for their collaboration and sponsorship for this wonderful program. And I believe that such collaboration and partnership will help improve awareness and as well as improve education and troubleshooting for patients who will benefit from such devices. Thank you. I wish everyone a good evening and a good weekend. Goodbye.
Thank you, Dr. Ching. Nice talking to you.
Thank you.
Bye-bye.
Thank you,
Jeremy.
Ching.
Thank you, Patrick.
Thank you, Dr. Aroa. Thank you, Dr. Chung, and of course, everyone for participating in this webinar. So I hope you stay safe and healthy. Thank you.
Thank you.